Alright, now we're at the home stretch. Let's finish off renal physiology with a quick discussion of renal tubular acidoses, or RTA. These are a type of acidoses, so they do apply in the schematic we just discussed, but they're special because they result directly from dysfunction in the kidney. Now, type 1 is also known as distal renal tubular acidosis because it results from a defect in the ability of the alpha intercalated cells in the collecting tubule to excrete hydrogen ions. Now, quick question, why would this result in hypokalemia? Remember, as sodium is reabsorbed in the collecting tubule, this creates a negatively charged lumen potential. And normally, both potassium and hydrogen ions flow into the lumen of the tubule to balance the charge. But since hydrogen ions can't be secreted in type 1 RTA, more potassium ions end up getting pushed into the filtrate, or pulled into the filtrate, you could say, by that negative charge, that negative lumen potential that's there. Now, there's also an increase in the risk of kidney stones with type 1 RTA. And this is because the urine has a higher pH, since the hydrogen ions aren't being secreted in the collecting tubule. And the higher pH can lead to precipitation of calcium phosphate. Now, causes of type 1 RTA include amphotericin B, analgesic nephropathy, and multiple myeloma. Next, type 2, or proximal renal tubular acidosis, results from a defect in the proximal tubule's ability to reabsorb bicarb. So, blood bicarb concentration decreases and bicarb excretion increases. However, the ability of the alpha intercalated cells in the collecting tubule, their ability to secrete hydrogen ions is still intact. They're still functioning. So this results in decreased pH of the urine as the body tries to compensate for the acidemia. So it compensates by increasing the excretion of hydrogen ions in the collecting tubule. And this also causes hypokalemia. Why? The bicarbonate that was failed to be reabsorbed in the proximal tubule travels to the collecting tubule and brings sodium along with it. As the sodium is reabsorbed in the collecting tubule, it creates a higher negative lumen potential, and this will result in increased potassium and hydrogen ion secretion into the filtrate. And causes of type 2 RTA include Fanconi syndrome and proximal tubule toxins like lead and aminoglycosides. Lastly, we have type 4, or hyperkalemic renal tubular acidosis. This results from hypoaldosteronism, or the inability of the collecting tubules to respond to aldosterone. Therefore, hydrogen ion and potassium secretion are both reduced. That's why it's hyperkalemic, as well as causing acidemia. So that wraps up renal physiology. Good job for getting through that. Let's finish with a flash quiz and a USMLE style question. What is the primary acid-base disturbance when the arterial pH is greater than 7.4 and the partial pressure of carbon dioxide level is greater than 40 millimeters of mercury? The answer is metabolic alkalosis. So the pH is greater than 7.4. So we know it's an alkalosis. And if the partial pressure of PCO2 is greater than 40, then we know it's not a respiratory alkalosis because a PCO2 greater than 40 would cause an acidosis. Therefore, the PCO2 being greater than 40 is a compensation and not the primary disturbance. The primary disturbance we know now is a metabolic one, and it's metabolic alkalosis. A 6-month-old girl is brought to the ED by her mother after ingesting a bottle of unmarked pills from the family's medicine cabinet. On examination, the child appears agitated and tachypnic. Urgent blood chemistry measurements are taken and reveal the following: sodium 143, potassium 4, chloride 104, bicarbonate 19, and a pH of 7.28. Which of the following medications did this patient most likely ingest? The answer is C, iron supplements. This patient is suffering from an acidosis because the pH is 7.28. And we know that it's metabolic because the bicarbonate is 19. And when we calculate the anion gap, we're going to subtract 123 from 143. So 143 minus 123, because that is the sodium minus the chloride and bicarbonate. And this gives us an anion gap of 20. And therefore we know that this patient has an elevated anion gap metabolic acidosis. And the only one of the answer choices that can cause this is overdosing on iron supplements. Now let's look at why the others are not correct. A is not correct because although aldosterone increases proton excretion, and inhibiting aldosterone would cause a metabolic acidosis, the acidosis in this case would be a normal anion gap. And we know that this patient has an elevated anion gap. Now B is not correct because antacids cause metabolic alkalosis, not acidosis. That's why they're called antacids. So that couldn't be what this patient overdosed on. And D is not correct because loop diuretics cause metabolic alkalosis because they increase hydrogen ion excretion. And E is not correct because opiates reduce respiratory drive and therefore cause respiratory acidosis. And the question stem stated that this patient had tachypnea.